Hello, this is Dr. Alison Peck. I hope you could see my first slide. And this talk is about 30 to 45 minutes. There are quite a few questions that I had before we got started. Thank you all so much for giving me those questions. I have some of them right next to me. But as we go through the course of the talk, I'm hoping that I'm going to be answering a lot of them. So if for whatever reason I don't get to your question, I will definitely save time at the end of the talk to go through as many as I can. So again, this is Dr. Alison Peck, and I'm one of the doctors of practice at HRC Fertility. I am a reproductive endocrinologist and infertility specialist, and I've been in this field since I graduated from my fellowship in 2006, and I've been practicing in private practice ever since, and I love my field, and I'm so blessed to be a part of all the patients I've helped create families, and I hope if you're looking to create a family of your own that I could be of assistance, and that at the very least, this talk will be educational and informative. So without further ado, we're going to get started. All right, so first off, good news. So there are so many ways and reasons that you guys should stay positive. Fertility treatment is really developed quite nicely in the last 40 plus years since its existence, and every decade something new and exciting happens, and we are always at the forefront of that new and exciting thing that we can offer our patients. So about 90% of patients will actually get treatment. And for those that are unsuccessful with treatment on themselves, there are plenty of other ways to create families. It won't be in the context of this talk, but there are other talks that our practice does that can help look outside the box for patients that are still suffering after the initial treatments are unsuccessful. So the goal of tonight really is to stay positive, that there is always something that you could do. All right, so we're going to move on. And again, tonight, what am I going to do here? Number one, I'm going to talk about what is infertility. Number two, how we treat infertility. And number three, what are the options for you to get help? So we're going to start in the beginning. What is infertility? The textbook diagnosis of infertility is broken up basically into two categories. Number one, if the woman, it starts with the age of the woman. If the woman is 35 years old or younger, and she's been trying for a year of having regular sexual relations around her ovulation window, and we'll get into that in a moment, and she is still not pregnant, then technically that's the diagnosis of infertility. If the woman is over 35 years old, then a 6-month interval is used. So if not pregnant within that 6-month period of time of actively trying, you get the diagnosis of infertility. All righty. So what are we going to need to make a baby? So number one, we're going to need healthy eggs. Number two, we're going to need sperm. And number three, we're going to need a healthy pelvis so the egg and sperm can meet each other. The egg and sperm are going to meet. Sorry, my pointer is not going to be working tonight, but we can focus on the last slide, number three. And this is a picture of the woman's pelvic anatomy. This is the vagina. This is the uterus where the baby grows. These are the fallopian tubes, and these are the ovaries. The eggs originate in the ovaries, and on a monthly basis, an egg gets released. We're going to talk about this in a minute. It waits in the fallopian tube for the sperm to come on in and find it and create an embryo in that area. So sometimes all of this is going to happen between a male and a female partner, and sometimes it's not going to happen that way. Sometimes we're going to be using eggs from another woman. Sometimes we're going to be using the pelvis from another woman, and sometimes we're going to be using the sperm from another man. Sometimes our partners are two females, sometimes they're two males. But at the end of the day, what unites us all is that we're always going to need eggs, sperm, and a healthy pelvis for them to meet. All right, so now that we've set that straight, I'm going to talk a little bit about some background of what happens inside a woman's ovaries on a monthly basis. So over here in the left side of my screen, I hope you're seeing the same screen as I do, we see a close-up picture of a caricature of what one little egg, which is here we're going to call the, just to focus us all, the primordial follicle looks like at the beginning of a month in a woman's menstrual cycle. And day one, if we go down to the graph on the right side, if you go to the very bottom, it'll say day of cycle, and it'll be numbered from the numbers 1 to 28. So day one is the first day a woman sees blood. So that's going to show us that blue graph on the right is going to show us what happens hormonally in the cycle, and the one on the left is going to show us physically in an amplified version what happens in the ovary in that month. So in the beginning of the month on an ultrasound, we can see a small little follicle. And in reality, there are a lot of little follicles, we call them, next to that are all little in the beginning. But one of those follicles is going to grow into an egg in the month, and it's going to release or ovulate. So as you see here, the little follicle, primordial follicle, is going to trail around at the top of the screen. Again, I hope you're following this okay. And it's going to move all the way to the right where you can see the word a ruptured follicle. So that process takes about 14 days in a woman who's ovulating around day 14, or a woman who has a 28-day cycle. After that, that little shell where the egg was is going to turn yellow. If you look right to the left of the ruptured follicle, we see something called a corpus luteum. And that shell is going to live there for the next 14 days, giving off some hormones to help support the uterine lining, thinking that there was an embryo trying to come in there and get pregnant. So please don't take this, get too distracted by the science behind this, but now that we're setting a tone of the importance of ovulation and a woman having eggs, it's going to help us carry on through the rest of the talk. I want to, before I move on, just quickly go over the graph and focus our attention again to those days of the cycle. So while that's happening in the ovary, what's happening hormonally in the body, and a lot of these hormones are originating from the brain and sending a signal down to the ovary. And a lot of these hormones we use as fertility doctors to help detect where a woman is in her cycle and if everything is working okay. So many times when we meet a patient, we're going to want to see them around the first, second, third, or fourth day of their period. At that point, we're measuring a hormone. So now I want you to look up where you see these nice pink lines and see what's happening with the hormones during this time. A very popular test that fertility doctors will get in those first 3 to 5 days is called the FSH and the estradiol. And these hormones help us decide how fertile a woman is. We can get into that in a little bit. That's an important window. So what's going to happen for the next 14 days, like I said, as that egg is growing and getting ready to release, there's going to be a surge called an LH surge, which you'll see in the middle of the graph. It's a nice little peak. And this is a very important hormone because so many of us use ovulation predictor kits or some version to try and see, is there any sign that my body could tell me when I'm going to ovulate? When that surge happens, it's your body's signal saying that you're going to release that egg within 24 to 40 hours. And then after that, the LH surge, that little peak you see, you'll notice it plummets really low. And another hormone's going to start to rise, which is in white, and that is the progesterone. And that hormone is created from that yellow follicle that I showed you before called the corpus luteum. And that's what's going to live there again for the 14 days, preparing your uterus for pregnancy. And if you notice at the end of when we get to around 28 days, you're going to see a dip in the progesterone, and that is going to bring on the next period. If a woman gets pregnant, the progesterone will stay high, fed by that corpus luteum, and she will miss her period. So again, forget everything that I said. I'm sorry I started with some physiology, but I think in many ways it will help women understand the tests that we do on them, why we do them, and why it's important to do different tests at different times in the menstrual cycle. So now we're going to move on. And we are going to review what I hinted at before of how how the body has to be working in the most efficient way for somebody to get pregnant, so that as we talk about the different problems with fertility, we can see what should be happening, and then we could compare that to what's not happening. So again, as I said before, the egg is going to be released from the ovary, and it's going to move into the fallopian tube. Now it's over here, and it's going to hit, oh, sorry, first slide. I'm so used to having everybody in front of me and being able to move the cursor. So we're going to put our energy on the very first picture. And in that picture, you see the egg coming out with an arrow into the fallopian tube. The next picture, you're going to see sperms traveling to the egg in the fallopian tube. And the egg is only really going to be there and survive for about 24 hours. So that's really the main window of opportunity for the egg and sperm to meet. Now, the people that are trying to get pregnant and and as far as they know right now, there's no fertility problem. It's actually the 6 days leading up to the ovulation moment that a woman's her most fertile, because sperm can live in the body of the woman for quite a long period of time, average maybe 3 to 7 days. So as you're having sex during that opportunity, that time, you're actually giving yourself an opportunity that it's not just the sperm that enters the body during that 24 hours that the egg is waiting for it, but the sperm that's been there for the days before also has an opportunity to meet that egg. So now that egg and sperm are going to come together in the third picture on the top on the very right. And this is when one sperm finds its way in, burrows inside the egg, creates an embryo. Once an egg and sperm have come together, now we have what's called our embryo, and that embryo is one cell at that time. And what happens is that embryo, look down to the second row, that embryo started off in the midpoint of the tube, but it's going to start to multiply from 1 cell to 2 cell to 4 cell to 8 cells very, very quickly. And as it's doing that, it's moving down the tube, and around 5 to 6 days later, it's going to end up into the uterine cavity. And you could see with the arrow a little circle, and that is now the embryo entering the uterine cavity. Once it finds its spot, it's going to start to burrow into the wall, and a blood supply is going to come, and that pregnancy is going to implant. And this is all happening during that 2-week window after a woman is ovulated. So around that 2-week mark, the woman's going to miss her period. So these are the things that have to happen for everything to go just right. And as we move on, we'll start to see how sometimes that's not what happens. And these are the patients that we are fortunate to see. All right, so before we get into the main types of infertility, I do notice, by the way, that some people are asking questions along the way. Please, please, please note that I'm not ignoring them. I just want to get through the flow of the talk, and then I promise I will go back and reference each one. I hope that's okay with everybody. So before we even get started with what are we going to do in a medical setting to help patients get pregnant, it's always smart to think about what you could do with your body, with your partner's body, if you have a partner, to improve your chances of getting pregnant. So I'm going to just highlight a couple of things on this list. Any of the things on this list are things you basically want to avoid for different reasons. And in many, many studies throughout time, each one of these things has been shown to lower the chances of somebody getting pregnant. So that would include things like toxic habits, smoking, alcohol use in excess, any kind of recreational drug use, some prescribed drugs as well. Fluctuations in weight or a weight that is not ideal for your height can throw off ovulation. Certain medications, as I mentioned, or supplements, you should always be asking when as you're preparing to get pregnant, your treating physician, do you know if there's anything about this product that can affect my chances of getting pregnant, or I shouldn't even be using this when I'm pregnant? For men, heat to the testicles, such as taking regular saunas and jacuzzis, wearing tight clothing. These are all things that have been shown to affect the movement and the shapes of sperm. Any type of toxic chemicals, chemotherapy, radiation, and sexually transmitted infections, most notably chlamydia and gonorrhea. So all these things are things that if you have this in your history, maybe it's smart to not wait a whole year if the woman's less than 35 to get checked before you start. If the woman's over 35, and again, this is in your history, you may not want to wait 6 months. So just things to keep in mind. There clearly are people that have had any of these things on the list, and it's not set in stone that if one of these things is in your history that you will not be able to get pregnant. But if you are doing your part and actively trying, these are things that you really want to avoid and cut out. All right, so now we're going to start to get into the meat of the different types of fertility problems. So we're going to start with number 1, the egg issue. Number 2, the anatomy. Number 3, the sperm. Number 4, the process of fertilization. And number 5, implantation. So I hope the previous slides has helped get everybody up to speed so we understand the framework of the talk. And we're going to go ahead and start with age and fertility, which is a little bit tricky sometimes because this is definitely something that a woman cannot change. We can't change our age. We could be proactive about the choices we make and when we want to start having children, but we should all know that as we grow throughout our lives, our egg supply goes down. We're born with a certain number of eggs that we get when we are in our mother's womb around 20 weeks. While we're in there, we're getting the highest number of eggs we'll ever have. And then once at birth, we've lost actually a majority of our eggs through a process called atresia. And then a woman eventually goes through puberty, if they do, and most women do, somewhere around, let's say, 10 to 14 years of age. And during that time, the periods are getting organized and the egg supply has substantially decreased at this point. And so for the next about 20 plus years of the woman's life, every month, the ovaries are losing and losing eggs. And as the woman's losing eggs, the quality of those eggs or the health of those eggs are also deteriorating. So I wish that there was a way to freeze time, and I will hint to that possibly at the end of this lecture when we talk in other lectures that I do on egg freezing or embryo cryopreservation. But from a natural standpoint, in the context of who we are, at what age we are, if you look at this graph, starting at the less than 30-year-olds to the 44 to 45-year-olds, you will see a steady decline and the effect of age on fertility. And what's interesting about this graph are when we get into the later part of the talk, when I'm talking about IVF and fertility rates and success rates, you will see that decline is the same decline we see in the success rates of IVF, because most of the success rate of treatment working, whether you're trying naturally or you're trying with help, has to do with the age of the woman. So the best I can say for this is the sooner you know that you're ready to try, or the sooner you know you're going to put off trying, you should really educate and do something about it, because there are plenty of options today to try to stop the effects of aging on the ovary. All right, so the other point that I'm just going to make is, if you notice on this slide that I said that the number of eggs go down in the last slide, but also the health of those eggs go down too. So on this slide, if you look on the left column, you could see how old a woman is, and then you can see in the other two columns what are the different risks of having genetic problems as the woman gets older. And a very common genetic problem when the egg and sperm come together is the egg is bringing in chromosomes, and some extra chromosomes or missing chromosomes that can lead to a baby with syndromes such as Down syndrome. And you can see the percentages, but the older the ratio, but the older the woman gets, the higher rate that she's going to have a baby with a genetic issue. And so it doesn't mean that somebody exactly at 35, all of a sudden, they're going to necessarily have a baby with a genetic issue, but the reason for loss rates or losing a pregnancy as women get older most likely is linked to the fact that the embryo is not healthy, and that's coming from the egg. So we're going to move on past this point and get to the next issue. So somebody asked before the lecture started about the different ways of predicting ovulation. And so I'm glad that I had this slide. I hope you're in the audience and you have an opportunity to see this. So this is ranging from 3 really simple ways to check for ovulation. Someone also asked an awesome question, I wrote it down, about a device called the AVA. That is a temperature tracking device to help women try and really hone in on the ovulation window. I have to be honest, I've never personally used that device, although it does make medical sense. But I think that the company itself says that maybe 89% of the time they feel that they're effective in finding ovulation. So I hope that person's in the audience today, and that was a good answer for now. But other ways to predict ovulation could go from something really, really simple, and that would be the first one, which is called the cervical mucus changes. And I show a picture of 2 fingers stretching apart. And not all women are fortunate enough to know their bodies so well or even see the signs, but somewhere around that LH surge that I talked about, which let's say is about mid-cycle, then a woman can notice that she's going to develop a vaginal discharge, which is going to be the consistency of the clear part of a raw egg. And it's really, really stretchy at that time, influenced by the hormone estrogen, which is coming from the growing egg. And that's your ticket to know my body's ready and it's waiting for sperm to enter. And this test, usually the best way to know is, if you are going to actually do this, that the stretch should be about 8 centimeters or larger. If you put your fingers together and stretch it, that's a perfect sign that the cervical mucus is ready and ovulation is very close. Another very common way to do this, this is an old picture. This is a picture of an old original kit of an ovulation predictor kit. If you notice, there's a C with a little line and a T. The T is the test line. The C is the control line to make sure that the kit's actually working. And women pee on these sticks. Usually I tell them, once you get to know your body and you get to know your interval of your cycles, going from the first day of one cycle to the next first day of the next cycle, and you track that for maybe 3 months, and you find a number, which common number is either 28 or 30, whatever that number is, you subtract 14, and that is the most likely day of your ovulation. And once you kind of know that, then I suggest women start using this around day 8 to 10, depending on when their cycle is. First, you want to see that it's negative completely. What you're detecting is the LH in your urine. You're waiting for the surge. That's why all these kits today are a little more complicated. There's happy faces and there's flashing happy faces, and there's peak fertility and there's low. But the point is, there's about a 6-day window of opportunity, I may have mentioned that before, leading up to the moment that you're about to ovulate. And any version of these kits can kind of tell you if hormonally your body is performing the way you see it based on when you're getting your period. So a lot of people like to proactively plan when they're going to be sexually active with these kits. Another way is to use a basal body temperature graphing. This is probably one of also a little bit old school, but again, many companies now apparently are using this methodology to help women track it a little easier. So a true basal body temperature graphing would require a woman to get a thermometer. There's special thermometers for this, for fertility tracking. And basically on the first day of the period, woman takes her temperature before she wakes up in the morning, before she eats anything, drinks anything, is sexually active. And she does that every day when she wakes up, and she graphs what her temperature was. And if you notice on this little temperature, there's going to be a little bit of a dip and then a little bit of a rise. It's so little, it's sometimes no different than 0.4 or 0.6 degrees. But when that dip is happening, it's a sign that ovulation is pending. And then after ovulation occurs, if you notice on this graph, graph, this is a biphasic temperature graphing. So that means that in general, there's a blue solid line tracking across, and you can see the temperatures at about 97.4 or something. Then you see the dip down and then a rise, and you see that the next horizontal line is actually a degree or two above the original. A degree actually, and that's the effect of progesterone. So when people are trying to learn about their bodies, if they have the patience and don't get frustrated by the basal body temperature charting, you can learn quite a few things about a woman. The most notably is number one, when ovulation's getting close to happening within a 24-hour window, and number two, you can see this biphasic pattern showing that the second phase of the menstrual cycle, which is called the luteal phase, again influenced by the hormone progesterone, is long enough to actually try to support the uterus to house a pregnancy. So without going too much more into this, these are the most popular ways of predicting ovulation today. There are some blood tests that can be done, such as checking a progesterone level a week after we think that you've had a surge to make sure it's high. Very common with a lot of the OBGYNs, but these are like the home ways of doing it without having to go get a test. So hope we're all doing okay. This is a little strange for me because there's no interaction, but I really hope you're enjoying this talk. So I'm going to go through a couple of the different reasons. I won't go in depth on any of them of why women most commonly have ovulation problems. This was another question that I had before I got started. So these four things are the most popular reasons why women will not be ovulating or releasing that egg. And simply, most women can know this just by getting to know their bodies, watching their menstrual cycle. And if they notice it's very erratic and they're not getting it every 28 days or so, or anywhere between every 25 and 35 days, we can already make sort of an assumption that we're dealing with at least an ovulation issue. That woman, I wouldn't have them waiting for an entire year or 6 months, whatever age they are, because we already know that if you're not ovulating, then you really don't know when to have sex. You don't know when your fertile window is. And those patients, I believe, should seek treatment sooner than my other patients. The most common reason for not ovulating regularly is something called polycystic ovarian syndrome. The picture on the left upper corner shows an ovary on ultrasound with lots of little cysts in it. This is a sign of polycystic ovarian syndrome. I'd say 40% of the time when there's an ovulation issue, that is the cause. But less likely are some other things like having a high hormone of prolactin in your body caused by a benign tumor in the brain. That's called a prolactinoma. The thyroid is a very important endocrine hormone in your neck here that helps regulate your metabolism and your heat and your cold in your body. And it also helps affecting your ovulation pattern and implantation and fertility. And then the opposite almost for lack of better terms in this talk, polycystic ovarian syndrome would be in a woman who really prematurely has ovarian aging, and the amount of potential eggs available has gone down incrementally faster than the average woman, where it usually is kind of depleted between 45 and 50. These women sometimes will go into an early menopause before the age of 40, and the reason they're not getting their periods is because of that egg supply being diminished. So again, we're going to move on in the interest of everybody's time on this evening, but those are the most common problems that lead to ovulation issues. Now, anatomy. So I showed you a picture earlier that it's very important we have a healthy pelvis for the egg and sperm to meet and for an embryo to implant. So that you see on the left. On the right, you see the most common things that a fertility doctor deals with when we're talking about anatomy issues that are causing blockages in eggs and sperm meeting each other, or problems with implantation. So some of the more common things, like I mentioned before, that could cause this is any previous exposure to chlamydia or gonorrhea, which are sexually transmitted infections, often not even known that a woman could have had those infections, and those infections love to block up the tubes. Well, if the tubes are blocked and that's where the egg and sperm can meet, then we're going to have an issue. And that's called tubal factor infertility. About 20% of the time we'll find that. Also, there are issues inside the uterus or the womb. Some women are born with, they would never feel this, they would never know this. One is called a septum. You could see that in the middle. This has something to do with how the uterus formed while you were a baby in your mother's womb. There are things then that you also develop in time, like uterine fibroids or endometrial polyps. So part of a fertility evaluation, which we're going to see in a moment, is to look for these things. One other thing that I should mention is something called endometriosis. So endometriosis, about 40% of our patients probably have endometriosis. Oftentimes, even us ourselves don't even know which patients have endometriosis. For years, in order to do an evaluation of somebody for fertility, we would always include doing what's called a laparoscopy, which I'll show you in a moment. I had another question on this when we're talking about the topic of an unexplained infertility, where it's not the eggs, it's not ovulation, it's not the anatomy, as far as we know, the uterus or the tubes, it's not the sperm, it's something else in the pelvis where there is something called endometriosis outside the uterus. And the only way we would know this is to do a surgery called a laparoscopy. Well, in many cases today, we don't do laparoscopies. Sometimes it doesn't improve the success of the patient getting pregnant. So that's not everybody, but in many cases we skip that step. So endometriosis is another heavy player in the world of fertility that could cause some issues and lead to, again, what we call usually unexplained infertility, or in this case, it really would be pelvic factor infertility. And again, there are going to be ways that we're going to talk about around that. All right, and now we are going to talk about a really important test. All fertility doctors have their own methodology and how they're going to work somebody up for a fertility issue. Some version of all the things I'm bringing up are most likely going to come up in your life if you go seek fertility treatment, but a very common one is called a hysterosalpingogram. This test is an X-ray. Dye is placed through the cervix around 7 to 10 days after a period and before ovulation. The dye is contrast material, and an X-ray is taken to highlight where that dye travels. And if you can imagine the pictures I was showing you before, in this particular image, there's an inverted triangle. That is an example of the walls of the uterine cavity. It filled up so nicely, so that's normal. And then next to it, you can see the dye tracking out and then dispersing in the pelvis, and that's a sign that the tubes are open. So again, not every fertility doctor is going to use this method, but this is a very common way without doing surgery on somebody to get an assessment if the pelvic anatomy is healthy. All right, so these are a couple of examples of what an HSG would look like if things weren't healthy. So first, the one on the top left is a normal HSG. On the right, if you can appreciate, there is a big dip at the top of if you look at the uterus, which is basically an inverted triangle, and you look at the top line going across, it dips down. That's because there is a fibroid pushing into the uterine cavity. And again, we would not want this. This would affect implantation. And looking down below, if you notice next to the inverted triangle, there are two almost, I'm trying to imagine if I didn't know how to read an HSG, what it's going to look like for you without me pointing. Sorry, but where the arrows are, that is showing where the tubes are. Now up above in the picture, the tubes didn't form circles because the dye was able to freely spill out of the tube. But underneath that, the tubes are swollen because they are closed and there's no place for the dye to go. And that is called a hydrosalpinx, and it basically stands for fluid in a fallopian tube. And that is what happens again in the event that somebody's previously had surgery in their pelvis or they've had a pelvic infection of some sort. Those are the two most common things we see on HSGs, uterine issues and tubal issues. And another type of test that we do, and sometimes fertility doctors choose to use this one in lieu of an HSG, but it will not give you, I don't believe, as good information about what's happening with your tubes as an HSG, but it'll give you great information about what's happening in the uterine cavity. So if you look above and across the row, there are three pictures showing in sequence what the inner lining of the uterus looks like in the first week after a period started, in the middle week right before a woman's about to ovulate, and then the last one is right around ovulation. And the main part to see, which again, I apologize for not being able to point, would be in the middle of the screen. The lining is looking like almost like a hamburger sign in the mid-follicular picture. And that hamburger sign, which looks like 3 lines, is basically showing that that is a great time that your uterus is getting ready to accept an embryo. If there was something in that space, doctors can float some water into the uterine cavity, which will appear black. So if you look right underneath that, you're going to see black in the middle, and you're going to see 2 white little areas. Those are called endometrial polyps. And the study that I'm suggesting that this is called a sonohistogram or a water sonogram. And again, I know this is a lot of medical information, but the good news is if you start to educate yourself and you understand some of these tests and you understand the terminology, that when any one of us, you go seek treatment and one of these treatments, one of these tests you do, you're like, oh yeah, I remember hearing about that one. Or if you've already had that before, then by all means, if you come for an office visit, please bring the films and the reports of these tests. All right, so we're going to move on. It's going a little slower than normal. I hope everybody's okay. And this I'm going to just highlight because I spend so much time talking about the female, but of course we need an active male participant to make all of this happen. So we're always going to have the man do a semen analysis to check to see a couple of parameters on what's going on with the sperm. Now, men are quite fortunate in that they have the ability to make sperm throughout their lives, always replenishing that on like a 72-day cycle, whereas women, as I said before, don't have that luxury. But in any case, the semen analysis can change each time a man gives a sample, and oftentimes we'll need to get more than one to really see if there's an issue. But just for the purposes of this talk, number one, we're looking that there's about 15 to 20 million sperm per milliliter of a sample that a man gives us on an ejaculate under the microscope to see if his concentration is adequate. And the movement should be about 50% of the sperm should be moving, and the shape of the sperm, about 14% of the sperm should look normal. And if for whatever reason one of these parameters is off, then we start to investigate further. Now, since we're talking about the man, what we usually do, since we are trained obstetricians, gynecologists that chose to go on and study deeper into the world of fertility, we are trained in the field of women's health and women and their bodies. We are not trained as male specialists, but we do work very closely with reproductive urologists, and that means that those doctors have trained specially after urology to go on and study the reproductive system of men, similar to us. So we usually start with some standard evaluations of the sperm. If we think that things are off, sometimes we'll do some blood tests or genetic testing. But if we need to rely on the expertise of our colleagues, then we usually will refer to a reproductive urologist for some assistance. And now we're going to say for the woman, so what are we actually going to do when you come to the office? So of course, if it's a male-female partner, then both patients should really do what they can to be present at the initial consultation. Like I mentioned before, there are so many different types of couples today, and there aren't always male-female heterosexual couples. Sometimes there are 2 women, 2 men. And so whether you're the male or the female, these are the tests that we're going to need. Both partners should be get a medical general screening, an exam, and then we start to do the workup. So for the female, we get some basic tests. We check that FSH and estrogen at the beginning of the period that I mentioned. We do a hormone called an AMH, which stands for anti-Mullerian hormone, and we do some type of imaging study. I think my picture is actually blocking the corner of this. I can't fix that, such as an HSG or the water sonogram. And then sometimes we end up having to do some version of a surgery in order to make a final diagnosis. So now that we're kind of moving away from some of the ways we're making that diagnosis, we're going to move into the different options for treatment very shortly. So I'll start with just a simple graph. This has to do with the different drugs that we use, oftentimes in the setting of a woman who's not ovulating. So the most popular drugs we hear are Clomid or letrozole, and sometimes you'll hear the words Follistim or Gonal F. These drugs are on the left at the top, and these are the type of drugs that are trying to help stimulate the ovary and allow it to release an egg or get close to grow the eggs. So that would be those. Some are oral, some are shots. And then HCG is a hormone that we use and under their human chorionic gonadotropin, which we use to trigger ovulation to copy an LH surge. And then some of the medication below are used for patients, whether it's thyroid medication or something called dopamine agonists, and these are for those times that I mentioned for women that aren't getting their periods because of some other endocrine disturbance. So if it's as simple as that, wonderful, but sometimes it gets a little more complicated, and we don't just stop at trying to induce ovulation or gather some extra eggs, but these are the most popular drugs the woman will be using during treatment for fertility. Okay, and now we're going to briefly touch on if it's as simple as, okay, it's not an ovulation issue, and maybe there's just a small something anatomically that's causing a disruption of egg and sperm meeting each other. And in that case, women would then go on to try to correct one of these things with some minimally invasive surgeries, which we do in our office at HRC and Encino. We have a surgical center. There's also a surgical center in Pasadena, in our Pasadena office. But what we do in these cases will be this wonderful slide. Number one, something called a hysteroscopy, or number two, a laparoscopy, and sometimes we do these simultaneously. So the hysteroscopies, these are same-day procedures, pretty quick, are ways in which we can enter the uterus with a camera. So if you look to the left, the top picture on the left upper part shows a uterus cavity inside with nothing in it, whereas underneath it, you could see a lesion on the left that's fleshy and red, and that's a polyp. And if you look to the other picture, the laparoscopy, this is how cameras go through the belly button, look around, and what you're seeing below that is a picture of a very healthy looking uterus next to fallopian tubes. And these are ways that we can do some minor corrective surgery. And oftentimes that's all a patient needs, but other times this is something that a patient would need in conjunction or before they're actually starting fertility treatment. Okay, so now let's get into more of like the meat and potatoes of what we do. If it's not going to be solved, if the problem's not going to be solved simply, then we're going to rely on some advanced fertility treatment, which goes under the topic of assisted reproductive technology, or ART, to try and help the patients create their families. So number one general topic is the topic of artificial insemination, which is where sperm is collected in a cup or from a sperm donor bank, and it's washed and cleaned, and then it's floated into the woman's pelvis at the right time. And the other is going to be the bigger topic of IVF, or in vitro fertilization. And I'm going to briefly talk about how these cycles differ and who is a candidate for each one of these things. In general, when the woman is about 35 years and younger, and we know we have some time to explore different options, it's not unusual that we may start with the artificial insemination treatment. And when women get to be 35 and older, when we know about those success rates and we know the importance of time and fertility and age, we're a little more aggressive or assertive, or we'll move closer through the world of past artificial insemination. But of course, this is a conversation with doctor and patient. And for example, if a woman's tubes are blocked, artificial insemination is not going to be helpful. If somebody is really just having an ovulation problem, sometimes we won't even do the artificial insemination part. We'll just help with ovulation and the patient will have timed intercourse. So this is a very, very general way to present the two main things that we do. So let's start with artificial insemination. It's usually done in about 3 main steps. This is a more simple version in that everything's going to happen within the woman's body. Nothing's going to be taken out of the body to help create a pregnancy. It starts with the beginning of a menstrual cycle. So a woman comes in on her period. We do a pelvic ultrasound. The left shows an ultrasound of an ovary that has about 4 or 5 follicles, we call them. How did we get 4 or 5 follicles? Usually, I said before, only 1 follicle is going to grow and release in a month, but oftentimes in an artificial insemination cycle, we're going to use those drugs that I hinted at before, whether it's Clomid or fertility shots, and we're going to use that to increase the number of eggs that the woman can produce in that first 14-day window while she's creating her egg for ovulation. And then when we are going to see her back in the middle of the cycle around day 10 to 14, we're going to do another ultrasound. We're going to see, oh, wow, it looks like you're about to release your egg. And then she's going to take a medicine, that HCG trigger shot, help the egg release. And shortly after that, within either the next day or the day after that, we're going to get the sperm. We're going to put it in a little tube, and then we're going to float it, if you see in this last picture, through the cervix up to the top of the uterus to try and get it as close to the egg we can, but we will not be there to actually get it into the egg, but we're going to get it as close as we can, and then we're going to wait 2 weeks and hope that the pregnancy happens. And I would say we're all a little different in how we practice, but good rule of thumb is maybe we'll try this about 3 times. It's rare that we'll want to try it more than 3, but definitely no more than 6. And if it's cumulatively effective, depending on how many follicles the woman makes, what type of medicine we give her, I'd say it's, if we don't give her medicine, somewhere between 5 to, let's say, 18% effective per try. And within 3 rounds, it usually goes up to about 20% or so. And if not pregnant after that point, it's a good time to check in and maybe discuss other options. Again, this is a very quick version of what to do. This is the topic of artificial insemination. If a woman doesn't have a partner, or a male partner, or the male partner doesn't have sperm, then we have patients go to the cryobank, get sperm, and this is the same process that we would use for donor insemination, with or without the stimulation of the ovary. Okay, so now we're going to talk about IVF. I'd say we're like 60% done with the talk, maybe a little more than that. And then I'll trickle back and try and answer some of those questions. Again, thank you. I see questions are popping up. IVF. So in vitro fertilization, meaning in vitro glass in the lab, we're going to be mixing egg and sperm in a petri dish in the laboratory to try and help fertilization happen. So this is going to be a process in which the eggs are going to have to leave the woman's body so that we have access to them in our laboratory. So the steps seem similar in the beginning. These are the first 3 steps. Number 1, the woman takes the hormones to allow her body to grow more than the 1 egg she makes a month. And in this case, the more the merrier. Of course, we're careful and we don't want to overdose anybody, but the more eggs a woman can create in a month, which is a direct reflection of her age and her fertility markers and how fertile she is, the more eventual embryos we're going to have off of a cycle. So the woman takes the medication. She's usually on them for about 10 to 14 days. The main difference is at the moment where we're getting ready to have those eggs released, we don't want them to release in the body because we want to get access to them. So right before ovulation, we put the patient to sleep. We do a minor surgery, takes about 15, 20 minutes while she's sleeping. The pelvic 1 ultrasound goes into the vagina. Number 2 here, you can see the picture. A needle pokes into the ovary, into those black circles, which is fluid. It drains out the fluid, puts it in a tube, looks under the tube, and the goal is to find these nice mature eggs. And the first part of the cycle is over. So at the left bottom picture, you could see the picture of a mature human egg. What's going to happen next? The lab is either going to choose to do something called IVF, where you take an egg, you put about 30,000 sperm on it, you walk away, you come back the next day, however many eggs a woman makes, and you check to see if one of the sperm figure out a way to get in all by itself to fertilize, versus a process called ICSI, or intracytoplasmic sperm injection, in which the egg and sperm are mixed. An individual sperm is mixed directly with one egg at a time. There's a lot of information on this, but in general, I'm going to just give you the overview, but this is how the egg and sperm come together versus ICSI. We'll get back to that at a later date, but for now, after the egg and sperm have come together, let's just go back one more slide because I love this slide. This is what's going to happen to your embryo when it, after the egg and sperm have come together between the first day to the 5th day, and actually we usually grow the embryos out even till the 7th day. So as I said before, naturally in the fallopian tube, the egg and sperm come together, they create an embryo, 1 cell, multiplies every day, 2 cells, 4 cells, 8 cells. And by the 5th day, it should be about 60 to 100 cells, and that's called a blastocyst. And that's what you see in the very right picture above where it says day 5. And that is the stage at which an embryo needs to enter the woman's body, like I showed before, to implant. Many times in the past, we would create the embryos, and around the 5th day, we would do the transfer, which is done very similarly to an insemination, where we put the catheter through the uterus, enter the embryos. In this picture, there are 2. Oftentimes, that's a conversation whether we'll do 1 or 2 embryo transfer. And in the past, again, we would do this off of a fresh cycle, but in many cases today, we actually freeze the embryos, which is called embryo cryopreservation. And this is a conversation you can have in the office of what's the benefit of doing a fresh versus a frozen transfer. But in any case, once that embryo goes inside, that's the end of the cycle. We wait about 2 weeks to see if we're pregnant. And that would be considered the end of an IVF cycle. So a couple things I want to bring up before we get close to wrapping this up and answering some questions. We'll start with, just want to make sure you're all still there. I think you are. So we're going to talk about briefly a topic called pre-implantation genetic screening diagnosis, which is actually today called pre-implantation genetic testing, or PGT. When I originally was writing this talk, and this was a couple years ago, definitely, this was a kind of a new technique, and not that many practices were doing it, but it actually got started in the 90s, and this type of technology was used to test embryos before they actually go back into the womb to see if there are genetic issues with the embryo. But today, for many reasons, as the technology has advanced, the majority of the cycles, at least as of now in the present at HRC, we actually are employing pre-implantation genetic testing. So if you are a patient that's considering doing IVF, I talk about this at every single consultation, that at least you should know your options, that you can have your embryos tested before they actually go back into the body. One of the main reasons why this testing came about was to try and find people who carry genetic syndromes that are trying to avoid their babies from getting these diseases. But after that came a new version of the field, which, well, it's not just that we want to prevent a rare genetic disorder in patients, but we want to universally try and optimize the embryos we do choose to put back into a woman. Because if we could check those embryos to see if they have the correct number of chromosomes, which is 46, we know that that embryo has a really solid chance of being successful in creating a baby. Whereas if it doesn't, such as in the case of Down syndrome, where you get 47 chromosomes, then we know that baby most likely will miscarry or potentially will be born with some issues. So there's definitely some ethical questions around our field. This is one of them. But at this point in history, the majority of cases are employing PGT testing before patients do have their embryo transfer. So I encourage you all to consider that and look into that if this is a treatment that you will be doing. To summarize, who are the people that really are actual candidates for doing this type of treatment would be on our right. So women over 35, family history of genetic issues, and patients that keep getting pregnant, but they lose their pregnancy or have lost a pregnancy for a known genetic issue. In time, that could really weigh on a couple or a person. And this type of testing for those particular couples is quite effective in helping us find healthy embryos to increase their chance of having a live-born baby. And then there are a couple of other things on the list. In the interest of everybody's time and the hope that you're all seeing me, I'll go through the next couple of slides. But one thing that people do use this treatment for, which always wows the crowd, but is becoming more commonplace, is not only do you get to see if the baby has the right number of chromosomes with this testing, but it also shows the gender. So for people who are curious or desiring of choosing one gender over another, this would be the methodology in which we use. Okay, so what are some of the risks of going through this treatment? This is a cute little slide of many, many babies, but clearly the number one risk of going through any kind of fertility treatment is, although we want that pregnancy, the caveat to that is we're trying to avoid having a woman carry too many babies at the same time. So there are quite a lot of restrictions on the number of embryos we can transfer, as well as how many follicles should be there before we do an insemination procedure, all under the context of trying to create the healthiest pregnancy for a woman. Because although many patients, about 20% of the time, women will end up with twins, or many patients want that, we do have to try to encourage the healthiest pregnancy, and that is a singleton. And we like to watch, or I watch my patients throughout the first trimester. So once you find out that you're pregnant, you're considered 4 weeks pregnant. Most of the patients are on some type of supplemental hormone, such as progesterone, which I hinted to earlier in the lecture. And this hormone just tries to keep the pregnancy intact through that first trimester, while that corpus luteum that I talked about, if you remember before, in many cases, it's been disrupted, or it's not even there if we do frozen embryo transfer. So that is really the source of the progesterone for the first 8 to 10 weeks of pregnancy. So we supplement with progesterone. And so if you do come through, don't be surprised that you will probably be on some version of progesterone till it's anywhere from around 10 weeks to sometimes 11 and a half weeks. We also want to make sure that although the patients end up with a positive pregnancy test, that the baby is growing inside the uterus, and somehow it didn't float away and go into a fallopian tube, which is a no-no pregnancy, high-risk pregnancy, unable to carry a pregnancy like that. And we need to somehow stop the pregnancy before it gets too big. And of course, we want to watch that the baby will meet all of the milestones we want to see in the first trimester, to make sure somebody's at risk for a loss. If there's anything we can do to prevent that, that we are available to do so. Okay, so this is an old slide, but it's just an idea of what happens in the success rates with IVF. So the most overall, I usually tell patients that they're between 30 and 40. It's overall about a 50% per try, cycle by cycle. Our more fertile patients or our younger patients, I think that rate is more close to about 60-70% per try. It also depends on how many embryos we put back in. The older a woman gets, though, because of the things I hinted to in the beginning of the lecture, as you see this dipping down sign, you will notice that the rates start to really deplete. So we are always encouraging of the sooner you want to do this, the better. We don't like to waste too much time in the simple treatments if we feel like they're not effective. If patients are delaying their family planning, then we do encourage patients to freeze eggs or freeze embryos in their youthful years to come back at one day in the future to have a transfer. This slide, the most popular question, in case anybody has it, is how come it looks like the 35 to 37-year-olds were at 77 almost percent pregnancy rate, and that's higher than our less than 35-year-olds. Well, every year we report our numbers to SART, S-A-R-T. This is how different clinics will report on their pregnancy rates by women's age group. That year, where we had this beautiful slide from our wonderful marketing team, was a very successful year in our 35 to 37-year-olds. But the point of this slide is to see the trend, the downward trend as women get older, and the general rates of IVF. Somebody had asked me before we got started, what are the rates in the population of unexplained infertility with IVF? Truthfully, at that point, a lot would depend on the age of the woman, and I would say that the rates primarily would follow similar to these numbers. All right, we are almost there, and I am so grateful. I really hope you're all still there. I hope that the browser situation didn't just happen again, which it looks like it did. So definitely troubleshooting here. Let me try to recall what I did, but really, I'm really just about at the close of the talk, and so I'll just talk for the next couple minutes and start answering some questions. But basically, the end of my talk usually says that as much as this has been, I hope, educational and informative and gets your feet wet into the world of fertility, something that I didn't talk about is how important it is to work on your stress management and your lifestyle and your health and your general health, and mostly your mental well-being. There's no shame in having issues with fertility. I am so blessed, and all the other doctors at HRC, we're all so blessed that we are in a position to help people create families. It's just such a joy for us to see it happen, and you should be proud. We all have challenges in life, and whatever challenge you get, I should be proud that there's a way to overcome these challenges and that we're here for you, and I'm here for you. And if there are any patients that are ready to take that next step and seek treatment or at least an evaluation, I do encourage you to come. I would be excited to meet you. And if there are any questions that I don't get to right now, because I think we're just about at that hour mark, then please note that either Monica or Kina, who helped me put this talk together in this way, will get them to me, and I will respond back to each of you in some version of an email. So I'm going to take for the next 5 minutes, I'll say. Let's see. So I'm going to go with somebody had asked, I hope I answered you. Again, this is somebody from a while ago. What are the top reasons for why an otherwise healthy woman would have trouble getting pregnant? I think that hopefully we dived into that, but I would just go back to either issues with irregular cycles or ovulation issues, age factor, something going on in the pelvis. Those would be my biggies. And of course, the partner, making sure the partner is okay. What is the best method? What is the best method to predict or confirm ovulation? I hope you were here to hear that great slide about the different versions, home ways, and the ovulation predictor kits. And then the basal body temperature charting. Is it worth it? I believe that once you get to know your body and you feel like you kind of got it down and you know if you're ovulating and about when, that you should throw it all else away and just try. Because I think after a while they get a little stressful and tedious, obvious. It's like peeing on a bunch of pregnancy tests and having them be negative. But for many people, it gives them a sense of control. Not everybody can have sex on such a regular basis. Things must be timed today. We have scheduled busy lives. So for those patients, I think it really does help. Somebody had asked, what can help you conceive if you have PCOS, and what are my chances of pregnancy at 42 years old? So I would go with the what can help you conceive if you have PCOS. I'm so happy. I hope you learned that when we were on the ovulation slide, that polycystic ovarian syndrome, which is the PCOS, mostly it's an ovulation problem. It usually starts with trying beyond maintaining a healthy weight and lifestyle is to try to go on some ovulation-inducing agents like the Clomid that I hinted at. There's also letrozole. And so usually it's treatments revolves around ovulation and making sure there's no other underlying issue. So if you do ovulate, that we won't get trapped with some other issue. And chances for pregnancy at 42. I hope that at least my IVF slide sort of gave you an idea, but that would be with treatment. I would say without treatment, it's clearly less than that. Maybe at 42, we're hovering in the 10 to 20% zone, depending on how fertile the woman is and what their ovarian reserve looks like. Naturally, it would be maybe 5% or less, again, depending on the other factors. I was able to see the first slides, but now there's nothing displaying. I hope that we were able to fix that. Something about the vouchers. After this talk, at any point, you are all welcome to have a free voucher. The staff will reach out to you to see if you want to make an appointment. So being part of this talk gives you a free voucher for a consultation. So, and then let's see, I am conceiving, but it always ends up being a chemical pregnancy on IUIs. I would always miscarry around 5 weeks. What may be the reason? I have polycystic ovary syndrome and I'm 27 years old. Okay, well, this does happen. As I said before, some of the things that could go wrong, whether you're getting treatment with an IUI or IVF, is some pregnancies will end up in a miscarriage, whether it's a biochemical, which is a pregnancy that sort of starts, you get a positive blood test and then it goes away before you even have a chance to see it. Sometimes that has to do with implantation problems or issues in the lining of the uterus, embryo not finding a good place to stick or not having the right hormonal environment to hold on to it. There are plenty of ways to help with that. And being that you're 27 years old, it's a fantastic age to be seeking fertility treatment. I would encourage you to come in and find out more. Are any of these issues Are any of the issues you discussed cause miscarriages? In my case, I have had 3 miscarriages between 5 to 7 weeks. I have a thyroid issue, but that is controlled with thyroid medication. So yes, some of these issues, absolutely. I didn't talk about it in the context of recurrent pregnancy loss. I really only hinted at that. Recurrent pregnancy loss would be in a woman who's lost more than 3 pregnancies. And I really only hinted to that when I talked about the PGT testing, but a lot of these things such as problems with the uterine lining or the health of the embryo is related to pregnancy loss. So that would be also a wonderful reason to come see us. We have a new program at HRC that is trying to study further in a more scientific and cost-effective approach on patients that are losing pregnancies to give the most up-to-date types of treatment, because this is a whole field in and of itself. Okay, thank you. Somebody acknowledged that you're able to see my slides. Several procedures require hormones. Is there any breast cancer risk? I have heard that breast cancer increases for those that use hormones. This is a fantastic question, always a little hard and tricky to answer this question. Patients that are at risk known to them or have previously had breast cancer, we are very careful about giving them the hormones. The hormones are not necessarily estrogen, which is in the breast cancers, oftentimes these cancers are sensitive to either estrogen or progesterone, but the medicines that we use will cause an environment in which estrogen is higher than natural. And so if somebody already has an active lesion or has gone through treatment, we really don't want to do anything to provoke a worsening of a breast cancer. In general, though, for the amount of time and exposure we have our patients on the treatment, it is significantly less than what a pregnancy would do and the amount of hormones a woman is exposed to in pregnancy. So this is not usually a deterring factor, although there is an association with high estrogen environments for long periods of time in a woman who is at risk. So it's kind of a great point, but at this point in time, we do not feel that they cause breast cancer, the fertility drugs. And I would love, if you come for a consult, to go deeper into that. For women over 40 or for a strong family history of breast cancer, I always suggest they get their breasts checked before they go into fertility treatment, whether it's by ultrasound or mammogram. And okay, where else? Okay, I think we're doing pretty well. I didn't get to everybody. I think that I've kind of overstayed my welcome tonight. So I think what I'll do is I'll start to troubleshoot all these questions. For any of you who I did not answer your question, I apologize. And I will make sure that Monica connects with me to make sure that you do get an answer. And thank you so much for joining me tonight in this interesting environment and sticking through with me while all the slides switched about. So I'm going to check out now. Again, I was at Dr. Alison Peck at HRC Fertility in Encino, and I hope you learned something tonight, and I hope you stay safe and you wash your hands and pray for all those people out there that are suffering from the coronavirus. And may we all work together to try and find ways to make this world a better place and take care of each other. So thank you so much and have a good evening. Bye.